So today I would like to talk about the entity of hypertrophic cardiomyopathy and its association with SAM, which is systolic anterior motion of the mitral valve. So LVOT obstruction is often seen in conjunction with hypertrophic cardiomyopathy. So this is a picture showing you, this is from the JO book on echocardiography, that there are different morphologies that are associated with hypertrophic cardiomyopathy. We usually think of hypertrophic cardiomyopathy as either diffuse thickening here in the neutral aspect, in neutral format, or maybe the sigmoid where there is disproportionate septal hypertrophy. But there's also other morphologies involved, such as the reverse curve or the apical variant, which if you were to fill this ventricle up with definity, it would look at it like an ace of spades. For some reason, this is much more common in the Japanese population. So one of the things I do want to mention that LVOT obstruction, and for that matter SAM, can exist outside the realm of hypertrophic cardiomyopathy, that any pathological state that alters the heart morphology has the potential of causing LVOT obstruction. I've seen LVOT obstruction status post valve surgery in Takotsubo hypertrophic cardiomyopathy. It can also be seen in LVH due to amyloidosis. It can also be seen in merely patients with overall left ventricular hypertrophy with small cavities. And when these people become dehydrated, their heart underfilled, they can develop this obstructive pattern. So just know that LVOT obstruction is a physiological state and definitely not just synonymous with hypertrophic cardiomyopathy. So a few words on assessing LVOT gradients in the setting of an LVOT obstruction. So this is again from the JO book, which says that the Mayo Clinic Cardiology Laboratory, their practice is to first assess the rest gradient. If the maximum instantaneous gradient is greater than 50 and no provocation maneuvers needed to be performed. If it does not reach 50 millimeters of mercury, you may consider doing a Valsalva. If your results are still not satisfactory and you are suspecting a obstruction, you may either do a provocative maneuver such as amyl nitrate administration or squat to stand to bring out to decrease the afterload and bring on the obstruction. So just to show you guys what SAM looks like, I'm using this doctor's video, which shows it very nicely. Here's an example of SAM where you see the anterior leaflet during systole is now drifting towards the septum. So what's going on is that during SAM, a lot of turbulence or in this case of LVOT obstruction, a lot of turbulence is occurring in this LVOT area, and this creates a drag force that actually is pushing the mitral valve into the LVOT. So this force can also cause mid-systolic closure of the aortic valve. And now here's a nice example from our own lab of a example of systolic anterior motion of the mitral valve. Here you see the mitral valve, the anterior leaflet during systole is drifting into the septum, which the septum here has asymmetric hypertrophy at the bulge, sort of like a septal bulge, which is one of the risk factors for developing SAM. So I'm just going to pause it and scroll through it really slowly. So during systole, you can see that the mitral valve is drifting into the LVOT, almost creating a complete obstruction. And what makes it, here we go again, almost complete obstruction. And where we could see this most dramatically is if we were to do a color Doppler across the LVOT. And let's slow it down again. You can see that in systole, there's just so much turbulence going into the LVOT, which tells you there's going to be a lot of outflow obstruction here. So let's go ahead and see what our velocities are going to be across the valve. I'm sure we are going to get higher velocities than these. So our velocities across the valve that we're getting, here we're getting upwards of 500s, so very severely elevated. And just for you fellows, just remember that we're identifying this as a waveform that's coming out of the LVOT rather than the mitral valve, because this is dagger shaped, which is a pathognomonic of an LVOT obstruction waveform rather than mitral regurgitation waveform. The mitral regurgitation jet starts over here and ends over here and across all systole. So the time between here to here is your isovolumic contraction time, and from here to here is the isovolumic relaxation time. So this is the duration of the mitral regurgitation, and here you see a little bit of mitral regurgitation here that cuts off, and then in between you have the LVOT, which is very nicely outlined here.